Hello, everyone, and welcome to Henry Schein's August 2021 update on COVID-19 on YouTube. Today, we join Dr. David Reznick for his update, where he will cover the latest information, including the continuing Delta variant, its symptoms, and its transmission rates versus the original virus, and a special section on vaccine misinformation that is unfortunately being widely circulated and followed. Welcome, Dr. Reznick.
Thank you, Gary. As usual, it's always a pleasure to be back and talking to you about where we are with the state of COVID-19 in 2021 and how it's impacting what we do and our families and our friends and our ability to return to normal. The Delta variant is basically turning into a fourth wave in my part of the country. It's sort of like a tsunami. And it's really impacting us hard because we're facing a shortage of nurses, we're facing a shortage of respiratory therapists, our emergency rooms are becoming overwhelmed, our ICUs are once again becoming overwhelmed. And it is a little bit, I can't say unexpected, but to this degree at this time of the year, I think it is. I remember looking at a slide back that I put together back in March saying that it looked like it was time for us to begin to think about having fun again. And I think we did. I think we've had some time outside. We visited with family. We've had a good vaccination rate amongst our profession. It can be better, and we'll talk about that. But then all of a sudden we have this another wave, and this wave is different than the first waves. And one of the things that we will talk about is how it's impacting children because of pediatric COVID, which really was not an issue with the ancestral wave. We'll talk about dental places being a great means because our patients trust us. They believe in us. They've been our patients for a long time. And the way that we can at least have discussions about vaccine hesitancy and even go through some of the false myths that are out there. We'll address some of those again because I think some of those myths are really keeping people away from getting vaccinated. And then look at the R naught value. I mean, we talked about at the very beginning that the ancestral strain was really not much different than the common cold. It wasn't that much contagious, and we were taking all these special precautions. And well, where are we now, and what's the R naught of this new Delta variant? So we have a lot of stuff to talk about, and let's get going. So what do we really need to know about this Delta variant? It's by far, and when I say by far, it is by far the most contagious coronavirus variant we've had in the pandemic. However, our vaccines are still providing excellent protection, and I think that's what we need to really focus on. When you see, the children that are being impacted, well, our vaccines are really only approved for people ages 12 and above. Although it does look like one of the two mRNA companies will be coming forward with data by the end of September showing that the vaccine is safe for those between ages 5 and 11. Nearly all of the hospitalizations and deaths that we are seeing in my hospital, and I'm going to show you data directly from my hospital, are amongst the unvaccinated, which is again why it's so important for us and our role as trusted members of the healthcare team to really talk about vaccinations with our patients. The U.S. Center for Disease Control cited Delta surge for its updated advice for fully vaccinated people to return to wearing masks, and that has been difficult. Just like everybody that's listening, I go to the grocery store, I do shopping, and to be frankly honest, I am most concerned about what I'm seeing, at least in Atlanta and in the suburbs, is that people, maybe 25 to 30% of people who are going into one of the major grocery stores are wearing a mask at this point. And I can understand that it's been exhausting. This has been 17 months of a change in the way we live. It's been 17 months in a change of how we do business. And it's understandable, but we have to protect ourselves. We have to protect our children. And as you know now, we're talking about giving boosters to those who are immunosuppressed. So we really have to make sure that we're taking care of those who are most vulnerable. So there has been a change, and it's looking at people who get infected with the Delta variant can easily spread this to others. And I don't know that people actually really understand this, that even if you're vaccinated, you still could have a viral load and not have any symptoms and infect other people. So I think that's some things that we need to look for. We do know that vaccines constantly mutate, and most changes really aren't a concern. A lot of the mutations just fall off. But the worry is that when we have unchecked spread, it can fuel more mutations. And our biggest fear is if we have a mutation or a variant that is not responding to our vaccines. We don't have that at this point, but that's something that you really have to keep an eye on. As someone who's worked in HIV for about 3 decades at this point, we started with watching these HIV variants start to show up and become resistant to medications, et cetera, et cetera. And the ability for HIV to change is so rapid, which is why we've had a much more difficult time getting vaccines against HIV as compared to coronavirus. Our success in this vaccine development is something we can never underscore. We really did a great job. But one of the things that we need to realize is that on the global scale, we're not getting the vaccines to many of our neighboring countries, to many other parts of the world. For those of you who were able to watch parts of the Olympics, you would find that a country as wealthy and successful as Japan is, Tokyo only had about 22 or 23% of people vaccinated against coronavirus. So as long as this virus is out there, and we have a Lambda virus that's now being the #1 spread in Peru, as long as we have this virus mutating, we could have the risk of developing a mutant or a variant that is no longer going to respond to our anti-monoclonal antibodies that we have for treatment or for our vaccines. In this variant, the Delta variant spreads far more easily and rapidly than our ancestral models. People are not protected by vaccines, are becoming getting infected faster and faster. And I will show you where my hospital was a month ago compared to where it is now, and those numbers are frightening. Delta variant now accounts for more than 95% of COVID cases in the U.S., and almost all of the cases that end up in the hospital are amongst the unvaccinated. Again, a role that we can play. If you look at the transmission of the Delta variant versus the ancestral strain, and I try to show this on this chart, there's 2 things that you can look at. On the horizontal axis, what you see is how infectious, say, the ancestral strain is versus the Delta strain versus, say, chickenpox. And then you can see also on the vertical line, the fatality rate on what is more fatal if you get it. So you see MERS is very high on that. Ebola, we all know, is very high on the fatality rate, but not nearly as contagious as the Delta variant is now. I do think it's a bit of an overstatement to say that the Delta variant is as contagious as chickenpox, because chickenpox really has an R naught of about 10, and we'll go into what the R naught of the Delta variant is. So the further you are to the right of the screen, the faster the disease can spread. The higher you go up on the screen, the more fatalities are seen and associated with this. And we can see that SARS is not really high on the fatality list, but we have lost well over 600,000 people in our own country due to this. And then you can see how contagious measles is being on the far right, and how deadly smallpox is. So just giving you an idea. With the ancestral version of the virus, an average sick person would go on to infect 2 people. So one person getting the virus would infect 2 others. Each of those people would go on to infect 2 additional people, et cetera, et cetera. By the end of transmission events, you go from one sick person to 8 people. The R naught of the Delta variant, however, is 7. So things escalate a whole lot more quickly. One person goes on to infect 7 people, and each of those 7 infect another 7 people for 49, and then those 49 people go on to infect 7 more people, resulting in 343 infections by the end of a 3 transmission event. So we're talking about 8 people versus 343, which is why the mask change was mandated for being indoors. It is a 419% increase in infections over the same period of time for Delta compared to the ancestral virus. So what I'm trying to let people know, it is highly contagious. We have high viral loads with this. It's something we still need to protect ourselves from. Here's a chart that just sort of shows you what I basically was talking about. So you can see at the top of the screen, we have our ancestral form where one person infects 2. Those 2 people can then infect 2 more, and those 2 more. And what you see is you have 8 at the end of the 3 cycles. And if you look at the purple blue, you can see one person is impacting 7. That impacts another 7. And you can see that our graph becomes quite cluttered with cases of COVID. If you look at COVID-19 amongst fully vaccinated people in my home state of Georgia, and this data is from January 19th through July 27th of 2021, about 5,000 people tested positive, 118 were hospitalized, and 24 died. That is out of 4,136,214 fully vaccinated people living in the state. So we had 4,900 who tested positive from that group, 118 were hospitalized, and 24 regretfully passed away. So this is just giving you an idea of the power of vaccination, and we do get some breakthroughs, but it's not all that common. Really what we're seeing are unvaccinated in our hospital system. So the next slide that I'm showing is basically our safety net hospital data, or the Grady Health System data. On the left part of your screen, you can see some yellow lines, some blue lines, some orange lines. The blue lines are when we were at our peak and we'd opened up the Georgia World Congress Center and set up a mobile ICU so we could take care of people outside the hospital because the hospital was full. And other, of course, hospital systems within the metro area use the Georgia World Congress Center as well. If you look at the yellow line on the left part of the page, what you can see, if you look around June, our numbers were around 8 to 10 people a day. That was it in the hospital. If you look to, and so you were really almost at the bottom of the graph. Now, if you look what's happened in the month of July, you can see that we are going on a straight line up. As a matter of fact, it just keeps on like crawling up the wall, and more patients. We have finally hit over 104 patients in the hospital now. We have several under investigation. So by far, our tsunami in Georgia is just beginning to hit, at least in the Atlanta area. It's been going on for a few weeks, unlike Florida and Texas and other parts of the country that have already seen this wave and are dealing with it. And they're asking for help from out of state. This is really another bout of a very serious pandemic. The right side of the screen sort of goes over a little closely where you can see towards the end of June, we were under 10 cases a day at the hospital. And you can see what's happened since and how the numbers are going up. And if I were to add the data from today, we would be over 100. So just showing you that this is taking off on a relatively rapid course. And our systems are getting overwhelmed. We are the safety net hospital. We are the level 1 trauma center, and we have been on diversion. Our nurses are getting worn out. We don't have enough nurses. We don't have enough respiratory therapists. And this is an issue wherever this pandemic is hitting hard. If I look at the weekly total for cases, hospitalizations, ICU admissions in Georgia, again, the numbers are really not good. This week, all the metrics in the graph increased. Cases were up by 47%. Hospitalizations rose by 28%. ICU admissions rose 17%, and deaths regretfully rose 146%. And usually you see a delay between the rises in cases and hospitalizations before you see deaths. In the summer of 2020, the delay was 3 weeks. The winter surge, it was 5 weeks. It looks like what we're seeing now is more like the 3-week or last summer delay. So about 3 weeks. I think it's important as clinicians for us to understand that some of the signs and symptoms of having the Delta variant are different than having the ancestral variant. We all know that cough, fever, shortness of breath are common with COVID-19 symptoms. That's what we talked about. That's part of our screening process and what we do. However, with the Delta variant, you might think you have a bad sinus infection or allergies due to a runny nose or a sore throat. And they're very common symptoms that we're seeing with the Delta variant. So the Delta variant can have symptoms that are milder and typically not associated with this virus that some may mistake as illness or allergies or other common symptoms. Sickness is what I just talked about. So even if you have any symptoms, no matter how mild, even if it's a sore throat or a runny nose, or if it's sinus congestion, and I live in the beautiful city of Atlanta where things are blooming constantly. And even though I have allergies to springtime, my fall allergies tend to be worse. We need to get tested if you've been in contact with other people that you might have been in contact with. Sneezing more than usual is also another symptom of the Delta variant. So we're talking about a series of allergies coming up and symptoms that are sort of similar to the cold, the flu, and other things. And I think it's important that we do our pre-screening calls, that we do get this information across to our patients. Dental settings are truly a valuable location for public health surveillance. And this was a prospective observational study over a 13-week period of time back late last year, of 4,000 asymptomatic screened patients attending dental clinics across Scotland who submitted to a combined oropharyngeal and nasal swab, which was transported to a lab for PCR testing for SARS-CoV-2 antigens. There were 22 positive cases during this 13-week period with an overall positivity rate of 0.5%, which reflects the underlying prevalence in the community. And that's the big point I want to make here. We can look at what the underlying prevalence is in the community via CDC data, which helps us realize what we might be seeing in our offices. Because remember, a lot of people who have COVID-19 don't show symptoms, either 50% are asymptomatic or pre-symptomatic. There's also an opportunity for dentistry to contribute to COVID-19 testing. And you know, from here, I've been a big proponent of doing HIV screening as a part of routine care. I think that we can do part of screening and testing for hemoglobin A1C or glucose as long as we have the proper CLIA waivers in place, as long as we have the proper lab systems put in place because we have to follow certain specific procedures. But the dental settings are a valuable location for public health surveillance and actually doing some testing on our patients if you so choose. It has been available, it's still available, and it gives us an idea if someone is positive or not. And whether we do that is up to your program. I work in a comprehensive outpatient program with physicians and nurses and advanced practice providers. We screen at the door and we do testing for anybody who does have symptoms. There was also a retrospective cohort study examining surgical logs and emergency medical records of all patients who sought treatment at an emergency department of the College of Dentistry at the University of Illinois at Chicago from June 2020 through December 2020, and determined that 203 consultations occurred during that period. Of those, 149 were tested for COVID-19 infection and 10 positive tests were identified for 6.7%. All 10 were afebrile and asymptomatic, the point that I just made, and 5 reported visiting a dental practice within 7 days of the ED consultation. So the cases at the university correlated significantly with the citywide positivity rate, a point that I was just making. So you can sort of tell what might be coming into your office based on what's going on in your community. And here I think is probably I guess my most important concept or statement. And I've said this before. Since the beginnings of HIV and the updated standard precautions, we treat every patient as if they have a bloodborne pathogen. We don't know. We don't know who has HIV. We don't know by looking at most people who have Hep C, whether they have Hep C. There's all sorts of steps that we took in place. We really don't know who has asymptomatic or pre-symptomatic disease that is coming into our offices. So as far as I'm concerned, and this is my opinion, we need to treat every patient as if they have an airborne pathogen. So until further notice, wearing your N95s, making sure you have on eye protection, making sure you're wearing a disposable gown or a gown that is washable, make sure that you're gloving appropriately, that you're covering up the end of your gown or your coat. And these are just basic things that we have done. And the reason our positivity rate has stayed so low is that most of the things that we're doing, we have been doing before and been doing for a long time. I think the biggest issue we have is wearing these N95 masks, and I think that are respirators, I should say. But until further notice, and since we don't know, I think being safe is the way to go. Being conservative and assuming that anybody could walk into your practice having COVID at this point is a reasonable assumption. So oral health care providers, when you look at this oral health care rate of COVID-19 infection reflective of community prevalence that was published in JADA, oral health care providers tend to have little information on positivity rates for COVID-19 in their patient populations that are seeking care. The authors conclude that the risk of there being COVID-19 infection in a population seeing oral health care, the current positivity rate in the geographic region of the practice, and they encourage dentists to have up-to-date knowledge about the current disease prevalence in their community. And as I mentioned, the CDC does track this. There are other areas that track this. You can look at COVID positivity rates and do a search and find out whatever source that you want to find, COVID tracker or Bing or Google or CDC or HHS, wherever it comes from, know how the disease is impacting your community. And for the most time, you can turn on the news and see what's going on. If you look at daily new and cumulative cases in the U.S., as of the 9th, we had 36 million cases of COVID-19 in the U.S. As of 8/9 on daily new cases, you can see it was over 235,000. We're back over averaging 100,000 cases a day. This has not gone away. We're still in the midst of a pandemic. The advantage that we have is that most of us are protected because we're vaccinated. And most of us are protected in the work environment because we've taken those extra steps to mitigate disease transmission, whether that be spacing out the number of people in the waiting room, whether that be wearing N95s, extra oral evacuation systems, high-speed volume evacuation for hygiene, dental hygiene assistance, using HEPA filtration, using virus killers, whatever your choice of the technologies are there. And I am overkill, so I basically have all the technologies in place. I want to make sure that my immunocompromised patients and that my staff stay healthy. That is you can't be healthy without oral health, and we need a healthy provider pool, and we need to keep our patients healthy. So what about vaccine hesitancy and misinformation? One of the questions is, how are these vaccines developed so fast? Well, we did have a warp speed project, and I know that name sometimes scares people, but instead of going in a stepwise fashion, we're going to test and test and test, and then after we get some positive results, we'll build up the manufacturing capacity so we can produce. This was all done simultaneously at the same time. And we actually had the genetic sequence of the ancestral model on January 10th of 2020. We also had a vehicle that had been studied for now it's over 12 years, these mRNA vaccines, where they could literally get that message and help you get that vaccine into our systems in a really fast time. So we had a lot of progress occurred before this pandemic looking at using viral mRNA. It was started by BioNTech and Moderna that allowed scientists to actually get this sequence from January 20th and turn it into a vaccine because it includes RNA. It does not include a virus. It does not include a killed virus or an attenuated virus. There's no need to grow the virus in culture, which is difficult and takes a lot of time. So when you get your flu vaccine, at least up until now, they were growing that in a culture based on something they saw a year before, so you have that delay. We have the genetic sequence. We were able to put it in these mRNA technologies and get the antibodies to you as soon as possible. So a great step. Some of the other things that are out there that are sort of interesting, the COVID, that's the word I can come up with, the COVID vaccine makes you magnetic. You might have a magnetic personality, but becoming magnetic because of the vaccine really isn't something that happens. The COVID vaccines are causing COVID-19 variants. That's not the case. As a matter of fact, the COVID vaccines, if we were all vaccinated and there would be very little circulating COVID, there wouldn't be any variants. So that's the opposite way. I think the one that really is holding up and one we really should take seriously is the rumor that's out there that the COVID-19 vaccine makes you infertile. The American College of Obstetricians and Gynecologists concluded that the vaccine should be offered to and is safe for people who are thinking about becoming pregnant, wanting to become pregnant, are pregnant, and who are breastfeeding. So this is a point that we really need to get across, because I keep on hearing, and I hear it from staff, I hear it from some consumer groups that we put together to find out what hesitancy is about this whole pregnancy issue. And I think that's something that we can communicate successfully to our patients. This one is one of those the next one's right along with the magnetic one, that the government is putting a microchip in the COVID-19 vaccines to track you. Yes, we have nanoparticles. This is not Star Wars. Facebook is not putting something on our brain to track us. This is just a false thing that's out there. Another one that I think is causing some hesitancy is that the J&J vaccine was created from fetal tissue. This is vaccine misinformation. Many moons ago, a strain of cells that was derived from a miscarriage was used initially to general vaccine research for coronavirus. This is a long time ago. The current vaccines do not consist of any fetal tissue. This was something that was done a long time ago. Muslim theologians and religious leaders, including the Pope and Jewish rabbis, have said this should not be a concern in deciding whether or not to get a vaccine. So this is more of a religious, ethical type issue, and I want you to feel comfortable realizing the vaccines that we have today are not made of fetal tissue and do not involve fetal tissue, and people more well respected in the religious world, such as rabbis and the Pope and Muslim theologians and religious leaders, have said, please don't use this as an excuse. Another one out there is that the COVID-19 vaccines can rewrite your DNA. While messenger, and I think that's what we forget about what mRNA is, messenger RNA does transmit information to the body and the cells. It does not go near the cell's nucleus, which is where the DNA is located. So I know that takes a lot of us back to our basic biology, which sometimes we try to forget. But this is a messenger RNA, and it's transmitting its message, and then it disintegrates. It goes away. So it's not like something that's going to stay in your system and change. The COVID-19 vaccine will cause long-term complications. This comes as a big surprise to most people, but the adverse effects associated with most vaccines actually become evident within 2 to 3 months of the administration of the vaccine. We're well beyond that now with COVID vaccines and have given millions of doses of it, so we know what the side effect profiles are. You can have soreness in your arm. There can be some exhaustion. Sometimes people get a little bit of a fever and flu-like symptoms, and it's gone in a day or two. So why do we really need to vaccinate and encourage even those most opposed to vaccination to be vaccinated? It provides the safest environment of care for patients. It protects our employees, our medical staffs in our hospitals, our staffs in our dental clinics, all the people that we need to do, and it affects our communities, our churches, where we gather. The COVID vaccines have been highly effective, have an excellent safety record, and are our strongest defense against the virus. Vaccines are better than wearing a level 1 mask. The FDA recently announced that the Pfizer vaccine will receive full FDA approval no later than the first week of September. And that's another reason that people are hesitant about getting the vaccine. They want to wait till full FDA approval occurs. So we basically know that FDA approval is going to occur within the next month. And I think that is important and hopefully will help convince people that aren't vaccinated to get vaccinated. The greater number of unvaccinated individuals in our communities, the longer COVID-19 will persist, and the greater likelihood of the emergence of potentially even more dangerous variants in the future. So really, this is very passionate to me. This is something that we can do as trusted healthcare professionals within our community. We ask all of our patients when they come in, have they been vaccinated? Would they like to get vaccinated? And we make every effort now to try to and we have been since the beginning. So literally, I did ask for questions last time we were on. And the question that came in as the question of the month was, I had COVID-19. Should I get vaccinated? And the answer is yes. Plain and simply, it's yes. Even those who've had COVID-19 should be vaccinated, suggests data from the CDC. A recent CDC MMWR, or Morbidity and Mortality Weekly report, showed 2.3 times the number of reinfections with natural immunity compared to breakthrough reinfections in those who are vaccinated. In other words, yes, you'll form some antibodies with natural immunity if you've had it, but you get a whole lot more breakthroughs with just natural immunity. If you wait those 90 days after you've had COVID and you get the vaccine, you're actually almost super protected. You're even more protected than someone who just got the vaccine alone. So again, another reason to get vaccinated, even if you've had COVID. So you've had COVID, I have some natural immunity. Do I have full immunity? The answer is no. You really do need to get the vaccine. So what is the vaccination status in the United States? More than 70% of adult U.S. population has received at least one dose. And I almost wish we would stop counting that number, because if you look at mRNA's success against the Delta variant, with one dose, it is 33 to 38% effective. That's not a lot of coverage. With two doses, you're talking 88 up to 98% coverage. So that's why we need more people fully vaccinated. We are over the 60% mark of the U.S. population, the adult population being vaccinated, so we're heading in the right direction. Of all eligible Americans, meaning everyone over the age of 12, about 68% have at least one dose, and a little bit less than 60% are fully vaccinated. Again, we need to get that number higher. However, in some U.S. states, and we'll go over that shortly, the vaccination rate is well below the national average. Nationwide, there are still 93 million Americans who have not gotten vaccinated. If you look at the daily new vaccination rate in the U.S., you can see in April there was a big surge, and then it started to go down as the warmer months came down. We are seeing upticks in vaccination, but it's not yet really showing up on my graphs. So in other words, there are more people getting vaccinated now, but we don't have those huge centers like the Mercedes-Dome Stadium in Atlanta. It is not open for vaccination now. Our hospital, walk in, you can get vaccinated. And so we are trying to make it easier to get vaccinated, but we're not having those mass numbers that we saw. And that's really what we need to see in the areas that are really getting hit, like Louisiana, like Texas, like Florida, like Georgia, like some of the other states that are in the south parts of our country. If you look at the national progress by doses per 100 people, the darker blue areas are where they're doing better. The really light areas are our most vulnerable areas. So you can see, even though Florida is having an issue, and I know that, like I mentioned before, elective surgeries are being postponed in parts of Florida and parts of Texas, and possibly soon in parts of Georgia. Florida does have a darker blue number. They have done a better job of vaccinating than other places in the South, such as Alabama, Mississippi, Louisiana, Arkansas, Georgia, the Carolinas, and Tennessee. You can also look at some of a place where I've talked about before, Wyoming, where I have some dear family friends not doing the best job of vaccination. So you can just look at the vaccination rate here, and then you can look by age group. And we've talked about this before, that are people that were most vulnerable at the beginning, 65 and older, have done a really good job of getting vaccinated. But this Delta variant is impacting younger people. It's not just impacting 65 and older. It's impacting From children, our pediatric hospital is getting full of COVID cases. Last week, we actually lost a patient to COVID, a pediatric patient to COVID. Younger patients in their 40s and in their 50s are showing up. And if you look, even in the 25 to 39 category, we're getting both vaccines as less than 50%. Both doses. So we have a problem. It's not just something that's taking out the elder, more vulnerable people in our population, but it's impacting younger, healthier people who have a tendency to think that they're invulnerable. So again, working with all age groups, trying to get these numbers up is important. If you look at the state view, you can see, look at Florida. Florida, almost 60% have one dose, almost 50% have both doses, compared to my state of Georgia, where not quite 47% have had one dose, and less than 40%, 39%, have had both doses. And we're doing better than Alabama and Mississippi and Louisiana. Oklahoma's doing a little bit better than us, but if you look at these southern states, with the exception of Arizona, and Texas is doing a pretty good job too, but if you look at these southern states, we're well behind areas like Massachusetts, where 64% are completely vaccinated, Vermont 67%, Minnesota 54%, et cetera, et cetera. So we really have a ways to go. This doesn't give you an idea of your community spread, but it does give you an idea of your community vulnerability. There are considerations for the booster shot. There are people who have already gotten the booster shot, and those discussions are actually happening this week about having a third shot for people with weakened immune systems. We're trying to figure out that some countries have already started this, where they're vaccinating people who are 60 or 65 and older. There are some places where they're vaccinating people who are solid organ transplants, and there's a study going on now at NIH looking at whether we should be doing the third dose for immunocompromised people. And that actually will be held this week. It's clear that immunosuppressed populations in general do not produce an adequate immune response after receiving 2 doses. Such people, including cancer patients, potentially people with HIV who I serve, or solid organ transplant patients or autoimmune disease patients, generally do not produce an adequate immune response after 2 doses. So what do we do in those cases? But these people represent, and when I say these people, I'm talking about our family members, our patients, those in our community. Immunosuppressed populations represent less than 3% of the U.S. adult population, but they still make up about 44% of hospitalized COVID breakthrough cases. The small percentage of breakthrough cases are those who are immunocompromised. So that's why we're having this advisory group meet this week to determine, is this a proper strategy? You can look at the WHO says what we really need to not do these boosters. We need to get them to parts of the world that have very little vaccination. I understand that we need to vaccinate the world, but we also need to take care of ourselves at home. And talking about taking care of ourselves at home, what about pediatric COVID? Should we be concerned? There are close to 72,000 cases of COVID-19 reported in U.S. children between July 22nd, 21 and July 29th, 21, an increase of 86% over the previous 7 days, according to the American Academy of Pediatrics, compared to the 38,000 cases from July 16th to 22nd, and a year-low number of about 8,500 cases a month before. So what you're seeing in the pediatric population is following what we're seeing at Grady, what we're seeing in Atlanta. A month ago, wasn't much happening. Then we saw a big change. Then we saw even a bigger change. And that's what we're seeing in this pediatric population. The substantial spike near the end of July happened just as many were preparing to start the school year. In its weekly report, the American Academy of Pediatrics said the number of kids infected has steadily increased during the month after declining in the early part of summer. Children represent about 19%, almost 20% of overall virus cases in the last week of July. So it is impacting our children now. The AAP said it appears at this time that severe illness in children from COVID-19 is uncommon, and that's the best news. But there's an urgent need to collect more data on the long-term impacts. Children range from 1.3 to 3.5% of the total pandemic hospitalizations among states reporting. The locations reporting deaths by age said that 358 children had died during the pandemic as of July 29th, about 0.07% of the overall total. Nearly 4.2 million U.S. children have tested positive for the virus since the pandemic started, about 14% of the cases, according to the American Academy of Pediatrics. The number of sick children in Louisiana and Florida has drastically increased in the last couple of weeks, something that we could have prevented if we were masking appropriately, if we were doing good mitigation strategies, and if we were getting vaccinated. It's unclear why more children are sick due to the Delta variant outbreak, but medical experts believe the surges are because of how easy it is for the virus to circulate in unvaccinated populations. While cases amongst children are growing at an alarming rate, the Delta variant is not confirmed to be more dangerous in children than in adults. If more children get sicker, that's just because more children are getting the disease, said Paul Offit, a vaccine researcher at Children's Hospital in Philadelphia. It's clearly increased contagiousness, not increased virulence. And I think that's important because the worst case scenario is that we have something that has increased contagiousness and increased virulence. A recent study from scientists in London found that children who are infected with coronavirus rarely develop symptoms of long COVID. Researchers just found that 4.4% of kids have symptoms that last for 4 weeks or longer, and less than 2% have symptoms that go on for more than 8 weeks. Since the start of the pandemic, which is about 18 months ago in January of 2020, as I mentioned, 335 children aged 17 and under have died. I would not want that in my family. In that same 18-month time period, a total of almost 50,000 children aged 0 to 17 have died from all causes. COVID deaths for less than 1% of all deaths amongst children under 17. So good news, but children are getting infected and we don't want to see worse outcomes. There have been nearly 9 million Pfizer shots in teens. Serious side effects are rare. As of July 16, close to 9 million teens ages 12 to 17 have received the Pfizer-BioNTech vaccine, the only one approved for this age group. Among roughly 9,240 side effects, 91% were considered minor, such as soreness in the vaccination site, but 9% were serious, with 4% developing a heart problem known as myocarditis or inflammation around the heart muscle. Last week, a study published in the preprint server on medRx found that teens were at a significantly greater risk of developing heart inflammation after getting COVID-19 itself than from the vaccine. So as I just talked about, yes, that's a side effect we see in a really small percentage. If that child were to get COVID-19, the chances of developing myocarditis are significantly higher. Researchers looked at heart inflammation rates at about 14,000 teens diagnosed with COVID-19 and a similar number of vaccinated teens who reported side effects. They found that the risk of heart inflammation was 21 times higher amongst girls with COVID and about 6 times higher amongst boys with COVID compared with the vaccination group. So in other words, get vaccinated. That's the bottom line. So again, it's always an honor being here. I wish I had a little bit more upbeat news that, we had passed this. We're getting ready to go back to school. Our lives have changed. But really, we're sort of at an intermediate place. So we can go outside, take our masks off, be comfortable, spend time with family and friends and things that we weren't able to do in the earlier parts of the pandemic. But let me stress, it is not over yet. And as much as I like talking to each and every one of you on these monthly webinars, it would be great if we could go back to some other disease states and talk about other things that are happening in our communities. But right now, COVID is our priority, and we need to do what we can to get this in check and to make sure that whatever we're doing in our offices, we are providing the safest dental visit possible. So thanks again for your attention. I look forward to your questions as they come in, and I'm going to send it back to Gary. Take care.
Thank you for the timely update, Dr. Resnick. If you have any questions, concerns, or topics for future episodes, please email us at webinars@henryschein.com. And please subscribe to our Henry Schein YouTube channel by clicking the subscribe button. and click on the bell icon to be alerted to any new premieres. With that, we'll see you next month with another update in this continuing series. Until then, stay safe and stay informed.